Now, this idea of bringing people with so many different perspectives and different experiences together, well, doesn't always work here in Washington. But I'm a little enthused by all his comments. They might be different in communities around the country. Do you think, Risa, that's a rational thing to expect?
I know it is. You know, we've seen a lot of quality improvement efforts that just focused on a hospital or just focused on a doctor's office. What we're seeing now that's different is everyone getting involved across sectors, the business community, the healthcare providers, most importantly consumers, and using information to raise the bar. That's what we're seeing differently in communities literally all around the country.
And Carolyn, I love if you just talk to everybody a little bit about costs. I mean, you would naturally think that if you're going to improve quality, it has to cost more. Is that true?
The short answer is no. The really good news is we can provide care that is high quality, safe, and it's high quality, safe every single time without spending more. In fact, we can be spending a whole lot less. If you think for a moment about how much time you've invested, shall we say, waiting for appointments and trying to make appointments.
Investment, I love the terminology.
You start to get a little feel for what are the potential savings if we do a better job coordinating care. And consumers can be a very important part of making that happen.
Well, one area where quality of health care is known to have gaps is in those critical transition points in care. When a patient leaves the hospital to go home, there's a lot she has to do, and a lot of errors occur from either the information not being given out accurately or the patient not understanding it. So, Maine, tell us what you're doing to change that.
Hi, Dr. Oz. My name is Kathy Bragdon. I'm an RN care manager at a federally qualified health center based in Bangor, Maine. I'm one member of a care management team consisting of registered nurses, health coaches, and social workers. Like everywhere else in America, we have a problem with hospital readmissions. But through the use of health information technology, we are improving our ability to communicate with hospitals throughout the region so that we know when one of our patients is in a local hospital. If we see that one of our patients is in the hospital, we know that we need to watch out for them. For someone who just left the hospital, taking the right medications, knowing what to do, and making a follow-up appointment with a provider can be hard and overwhelming. If we, as primary care providers, don't intervene at this crucial juncture, our patients are likely to experience a critical gap in care. There are also lifestyle changes that they need to think about too. So that's when we really go to work. And when I say we, I mean a team that includes care managers, health coaches, a provider, the patient, and others involved in their care. When I call the patient, the first thing I tell them is why I'm calling and that I would like to work with them on whatever they would like to work on to improve their health. I tell them that it's not what Dr. So-and-so wants or what anyone else wants, it's up to them. If they don't want to participate with care management, they don't have to. It's a voluntary program. Most of them will say they would like to focus on making a positive change, like weight loss. And with that first small step, patient engagement begins. We have a lot of success stories, but they're not our successes. It's the patient who does the work. I'd like to share one of those stories with you now. When I first met this gentleman 6 months ago, he had a hemoglobin A1C of 11.1, which meant that his average blood sugar was 272. This is dangerously out of control. The goal for people with type 2 diabetes is 6.5 or less. After 10 weeks, it was 6.3 with an average blood sugar of around 134. And he was down to 1 oral medication. 3.5 months later, his A1C is 5.7, blood sugar averaging around 117. He's lost nearly 50 pounds. His wife has helped him every step of the way, and she's changed her life as well. Every time I see them, they've lost more weight, and I call them the incredible shrinking couple. The thing that is so important is that they shaped their level of engagement to fit their lifestyle. They decided how 3 meals would fit, how snacks might fit, how exercise fits in. I know that when people learn about their condition, ask questions, work with their provider, they figure out how to make it work. They're the ones in charge, and it's an honor working with them as part of their team. Thank you for giving me the opportunity to share what we were doing up here in Maine.
Well, thank you for what you've accomplished. Thanks for being a nurse. Thanks for shrinking that couple. And most of all, thanks for being a healer. So coordinating people's care, helping them along their journey, especially at a point when they're medically vulnerable, like leaving the hospital or going to their primary care doctor and leaving their doctor and then going to their specialist. All those are points of transition. Farzad, talk to me about information technology. Why is it so important that we do better at handing the baton off?
Absolutely. The transitions of care are really dangerous times, as you pointed out. And we are doing our best, and communities, doctors, hospitals are really exchanging information a lot more than they used to. But all too often, still, today, people show up at the doctor, like my mom did after her hospitalization, complicated hospitalization, and the doctor said, "I didn't get your paperwork.
Yeah.
Tell me what happened in your hospitalization." And that's just not fair. If we're going to ask that of patients, if we're going to ask patients to be the ones to coordinate care between their specialists when they leave the hospital, we have to at least give them the information and the tools they need to do that effectively, to be effective partners in their care.
Carolyn, let's talk about quality. I mean, is this really practical? Do we know what works?
We know a lot about what works. It is very, very helpful when people ask questions. And I know a lot of people find that a little scary, a little bit daunting. After all, he or she is the doctor or the nurse practitioner. But when patients speak up and express their concerns and their interest, it has a very powerful effect on the clinicians from whom they're seeking care. Similarly, at points of transition, it's very helpful if patients have a rough idea about why they're going from point A to point B.
Risa, you had a comment on this?
Well, I do, and we heard it from Maine. Choose one person to coordinate your care and get engaged with that person early and often, and then ask questions, and it does make a difference. The studies show that you can reduce rehospitalizations, which we all know represent sort of a failure of the system, if you do those simple things that Carolyn mentioned and have one person coordinating your care.
So we're hearing two very strong themes here. Patients need to speak up and get involved. However they define it. They can define getting involved any way you want to. And doctors and nurses need to create a culture that makes quality improvement the norm. Now, we've heard from a nurse in Maine. Let's go to the other coast, the other part of the country, and hear from a doctor in Washington State. Pete, are you there?
Good morning, Dr. Oz, and greetings from Seattle. My name is Peter McGuff. I'm a family physician and chief medical officer for University of Washington Neighborhood Clinics. We have 8 clinics throughout the Seattle area. And I think all of us know that physicians and other healthcare professionals really want to do the best job possible. And in fact, if you ask them, they think they are doing a great job. And one of the things we really need is information and usable data on, to use as feedback for how we're actually doing. And what's impressive is when we take this kind of information and put it in front of providers, they improve. You cannot improve what you cannot measure. And so by using information and data from sources like the Puget Sound Health Alliance, we've been able to learn how to develop data within our own electronic medical record and put this in front of our care teams at our primary care clinics. And what's really been exciting is, again, when you put information in front of these providers, they improve what they do. I do say that it's not data alone that's going to make things get better. We also need systems to help support providers and the rest of the care team in getting better. And so in having the systems and the care teams like the care managers that were mentioned earlier, we find we can do a much better job of taking care of patients with conditions like diabetes. And in fact, that was one of the first conditions that we started with. And over the year or two that we worked on this, we actually found all of our providers improving to the point that we were actually able to get diabetes recognition from the National Committee for Quality Assurance. And this led us to have scores that were towards the 90th percentile in the nation. So a really nice improvement. And we're using these same kinds of approaches to information and to health systems to improve care in cancer screening, care for depression and chronic pain, and heart disease. So a huge amount of potential for that. And we're very excited. It's something that providers and our healthcare partners enjoy. And I also know that this is very important for patients. As was mentioned earlier, patients with a variety of conditions like diabetes, if their condition isn't well controlled, they don't feel very well. And even though change is not easy, by bringing a full team to work with the patient and engage them in their care on things like weight loss, on things like exercise, and really connect them with the information that's important to tracking how they're doing, we find that they do much, much better. And not only do they do better, but they actually feel better. And so I think the whole move that we're having towards focusing on quality and making sure that patients understand why quality and the kind of numbers that we look at are important is going to make a tremendous difference for our patients, also for the kinds of quality outcomes that we want to see in our healthcare system. And as was mentioned earlier, I think a big difference in cost, because if you do a great job in managing conditions like diabetes, not only do patients do better, but we see a lot fewer complications and, as a result, a lot lower cost.
Pete, kudos for what you're accomplishing in Seattle, and thanks for joining us.